So next we'd like to call up Dr. Susman, who's going to talk about regulatory requirements for localized prostate cancer treatment indication.
Hi, good afternoon. My name is Daniel Susman. I'm a medical oncologist and deputy director within the Division of Oncology 1, which covers drugs involved in the treatment of GU cancers as well as breast and gynecologic cancers. So I'm going to cover regulatory considerations from the drug and biologic side, which has some differences from the regulation of devices that Dr. Antonio mentioned. So prostate cancer is a disease that has had a high degree of overtreatment. If the treatment of early prostate cancer was as simple as that of melanoma, where an early skin lesion is removed through local surgery with very little morbidity, there would be little need to focus our discussion on the low-risk local prostate cancer population. However, curative treatments for localized prostate cancer can result in significant degrees of morbidity, including urinary and sexual dysfunction, which are life-altering and often irreversible. Active surveillance has increased in its use over the past few years, which is an impressive achievement, given the high degree of anxiety men can have in the setting of known low-grade prostate cancer. However, a proportion of men on active surveillance do go on to have objective clinical or pathologic progression, which will trigger definitive surgery or radiation. The agency has seen interest in developing therapies, including focal therapies, biologics, even drugs, in the active surveillance setting to delay or prevent pathologic progression and subsequent morbid surgery or radiation. Importantly, the benefit of this approach is the delay or prevention of the morbidity of surgery or radiation, and the delay in irreversible morbidity can be considered clinical benefit from a regulatory standpoint. So in 2018, multiple stakeholders met at the FDA to discuss the development of therapies for localized prostate cancer, and I'm going to go over some of the topics, including endpoints and trial design that were discussed at that time. I'm also going to briefly discuss some of the challenges in the development of therapies for higher risk disease. So the outline of my talk is as follows. I'll briefly review the regulatory framework for approval of drugs and biologics and how combination products are regulated. I'll discuss oncology efficacy endpoints and how they determine whether a product receives traditional or accelerated approval, and we'll then apply this to the challenge of trial design in the localized low-risk population. So there are different regulations for medical devices, and for my talk, I'm going to focus on drug and biologic law. There are two laws that have led to the regulation of drugs and biologics. The Food, Drug, and Cosmetic Act for drugs require they be safe and effective prior to marketing. The Public Health Services Act requires that biologic products be safe, pure, and potent. And while these have slightly different language, the FDA Modernization Act minimized the differences and approval between drugs and biologics for all intents and purposes use a very similar evidentiary framework. So in our decision-making, we don't take into account issues related to cost, and we also don't regulate the practice of medicine, only the products themselves. So just to touch on the structure of the FDA Oncology Center of Excellence, or OCE, this is an overarching center that fosters unified interaction between three FDA centers, CBER, the Center for Biologics Evaluation Research, CDER, the Center for Drug Evaluation Research, and the Center for Devices and Radiologic Health, CDRH. So the Office of Oncologic Diseases sits within CDER, but we work closely with CBER for gene therapies or cancer vaccines, for example, and with CDRH for diagnostics and for the regulation of drug-device combination products. So some products are combinations of a drug and device or a biologic and device, and when that occurs, a decision has to be made about which center will be responsible for the primary review and which regulations will be applied, either device or drug biologic. So the Office of Combination Products will determine the primary review center based on the component of the combination that provides the primary mode of action, where the indication is treatment of cancer. So just as an example, if a cytotoxic drug is given systemically, but that isn't activated by a device locally, such as HIFU, the cytotoxic drug would be the primary mode of action to kill cancer cells, and CDER would conduct the primary review using drug regulations. So in the US, there are two approval pathways that can be used to approve a drug or biologic, the traditional approval pathway or the accelerated approval pathway. And the appropriate pathways relate to the primary efficacy endpoint of the trial. Traditional approval requires substantial evidence that the product demonstrates a prolongation of life, a better life, or an established surrogate. Common endpoints for traditional approval are overall survival, large clinically meaningful improvements in progression-free or disease-free survival, whereas accelerated approval is an expedited program which allows for earlier clinical endpoints other than irreversible morbidity or mortality to be used as long as they are reasonably likely to predict clinical benefit. So the endpoint most commonly used for accelerated approval in cancer trials is durable response rate in single-arm trials. And then because there is a residual uncertainty in terms of the meaningful clinical benefit, a post-marketing clinical trial is conducted to verify benefit. And this would typically be a randomized trial using PFS or OS as an example. So with that in mind, let's talk a little bit about trial design, efficacy endpoints, and how to look at the strengths and limitations of an efficacy result. So generally, there are two types of trials we evaluate in OOD, superiority trials and non-inferiority trials. There are also equivalence trials, such as those for generic drugs that I won't discuss today. The assumption for a superiority trial is that the product is superior to either placebo or an active control. For a non-inferiority trial, we're trying to determine the product is not worse than an existing treatment. And I want to discuss this in the context of focal therapies because there are highly effective standards of care for intermediate and high-risk localized prostate cancer, and it seems unlikely that focal therapies would be superior to these whole gland treatments with respect to oncologic outcomes, such as overall survival or metastasis-free survival. And so a focal therapy may need to demonstrate non-inferiority with respect to oncologic outcomes and superiority with respect to quality of life outcomes. So there are several assumptions that go into a non-inferiority trial, including that the control effect is constant over time and populations, that the control actually has an effect, and that you can reliably estimate that effect. So with that said, non-inferiority trials may be very challenging to implement for focal therapies. Treatments have changed over time, particularly for radiation therapy, where higher doses and improved coverage has impacted oncologic outcomes, particularly for higher risk prostate cancer. And as imprecision in non-inferiority trials biases towards a finding of non-inferiority, use of endpoints that may be subject to imprecision, such as those dependent on relatively infrequent imaging, are problematic. So a non-inferiority trial in the setting is likely to be very large, and there are challenges in interpreting time-to-event endpoints other than overall survival. So with that in mind, I'll switch the focus back to lower risk disease, considerations for different efficacy endpoints, and looking at the strength limitations of a result. So the strength of an efficacy result can be evaluated by looking at what is measured, how it is measured, and how much of an effect is demonstrated. What is measured is important for the reasons I discussed regarding direct measures of clinical benefit, like prolongation of life, or improvements in symptoms or function, since they are considered more clinically meaningful than surrogate endpoints. However, one must also look at the measurement characteristics of the endpoint. How accurate and how much variability does the measure have? How susceptible is it to bias? And how accurate is the timing of the event? Some endpoints, like patient-reported outcomes, are strong in what they measure, it's a direct benefit, but may have challenges in their susceptibility to bias in open-label settings. Finally, how much of an effect is important? Large effect sizes can mitigate some of the weaknesses of an endpoint. For example, an 80% response rate with a median duration of 18 months in a third-line pancreatic single-arm trial with acceptable safety would be hard to run as a randomized trial with OS as a primary endpoint. On the other hand, even overall survival can have a statistically significant benefit that may not be meaningful in the setting of burdensome toxicity. So looking at this more closely, here are a few examples of increasing levels of required interpretation and subjectivity in endpoints that can add risk for bias and variability. So in this figure, the lowest risk for interpretation would be overall survival, one's either alive or dead. Progression-free survival for measurable tumors like breast and melanoma requires a little more interpretation and can be subject to investigator bias. Radiographic PFS in prostate cancer requires even more interpretation because it uses bone scans. Finally, preventing a morbid procedure requires a decision to act by the investigator and patient. For example, palliative radiation is one component of the composite endpoint of skeletal-related events, or SREs. And for this event to occur, the patient must first report the pain to the healthcare provider. The healthcare provider must then assess the pain as focal and related to a known bone lesion that is amenable to radiation. And then both the patient and physician need to agree to radiate the lesion. This is particularly relevant to trials in the local cancer setting where the primary treatment is morbid, such as bladder and prostate cancer. Preventing the morbidity of the procedure is a real clinical benefit, but the endpoint has a large amount of subjectivity and has risk for bias, increasing regulatory uncertainty. Another component of the measurement characteristics of an endpoint is the timing of the event. For time-to-event endpoints like PFS and OS, timing of the event affects the magnitude of the result, which is used to assess risk and benefit. Whereas OS is known to the day, PFS is only as accurate as the frequency of the scanning intervals. So looking at the strengths and limitations of OS, it's clearly a strong endpoint. It's a direct measure of clinical benefit, prolongation of life. It has a low risk of bias as the event requires no interpretation and the event of death is known to the day. It also captures both efficacy and safety. The challenge, as we've been discussing, is that this is the last event in the natural history of the disease, and this affects the feasibility of trials. So let's finish by applying this regulatory framework to low risk localized prostate cancer. Active surveillance has been very successful at reducing overtreatment of low-risk prostate cancer, but as I mentioned, patients do go on to receive morbid procedures. There are several challenges for trials in the active surveillance populations. First, endpoints that have led to FDA approval in prostate cancer, such as overall survival and metastasis-free survival, are impractical. Second, delaying a morbid procedure like curative, radiation, or surgery is clinical benefit, but as I mentioned, is subject to bias and increases regulatory uncertainty. Third, PSA anxiety can drive patients to go on to receive definitive treatments without pathologic local progression. So even if the intervention delays these treatments, it's delaying the morbidity, not the procedure itself, that's the clinical benefit. And so acute and subacute toxicity of any intervention in the active surveillance space must be well tolerated. Lastly, there is some concern that delay of a needed surgery or radiation could reduce the cure rate and have higher morbidity if the curative therapy is given after an earlier focal therapy. So to illustrate this issue, here are some of the clinical outcome and biomarker and imaging endpoints from the Hopkins Pound series post-RP. So these patients are higher risk than active surveillance population, and so the timelines for the active surveillance population will be even longer. And as you can see, the clinical outcomes in blue that are not preventing or delaying morbid procedures, namely metastatic pain, skeletal-related events, and overall survival, occur over a decade from PSA relapse, even in this higher risk population. MFS has been used to approve drugs, but this endpoint is also likely to be very hard to power and will take many years to mature. So again, looking at the strengths and limitations of the clinical outcomes from this timeline, OS is a direct benefit and has low risk of bias, but it's impractical. MFS is an important endpoint that defines an important change in clinical state and risk for cancer morbidity or death, and has been used to approve several drugs in both the castration-sensitive and non-metastatic castration-resistant disease setting. It's a strong endpoint, but as we've shown, this endpoint also occurs late in the natural history of the disease and also requires a very large and long trial. And we also don't yet understand how the clinical meaningfulness and feasibility of capturing this endpoint will change in the era of PSMA PET scans. So delaying or preventing definitive local therapy and its associated morbidity is considered clinical benefit, but this endpoint is challenging due to the risk for bias, which is compounded by patients who often have high levels of PSA anxiety. On the other hand, this endpoint is more feasible than OS or MFS in this setting. Patients are monitored in active surveillance, and a portion will have biopsy or other clinical progression that triggers a recommendation to undergo curative treatment. Objective local progression has lower risk of bias and is feasible. However, objective local progression is not a measure of clinical benefit in and of itself, and therefore be considered a surrogate endpoint more appropriate for accelerated than traditional approval. So regardless of all these challenges, we are receiving trial designs in this space, and I've heard from some investigators and patients that the active surveillance population is an area where therapies could delay or prevent morbid procedures and should be studied. The following few slides present a straw man trial design for consideration that attempt to address the issues and stimulate discussion. With respect to efficacy, OS and MFS are impractical. Delaying morbidity from local progression is meaningful but subject to bias. And so one path forward could be to use a pre-specified definition for local progression based on existing active surveillance protocols as the primary endpoint, with supportive data on clinical benefit provided by delaying or preventing morbid curative local therapy. So in this case, both endpoints are feasible. The clinical benefits demonstrated by delaying the morbid procedure, and the bias is mitigated by using objective, pre-specified triggered come off active surveillance via biopsy results and other objective signs of local progression. I'll note again that it's not the delay or prevention of the curative local therapy itself that's the benefit, it's the delay in the morbidity associated with that treatment. So again, if the curative therapy was an outpatient skin surgery for early melanoma, this design would not work because the curative therapy has very little morbidity. Because of this, the key morbidity of curative local therapy, urinary and sexual dysfunction and bowel dysfunction, must be measured well. PRO tools exist for all these morbidities, and the adequacy of the PRO tools for regulatory purposes should be discussed with the FDA. The data from patient-reported outcomes can be descriptively analyzed for safety, but could also be another statistically tested key secondary endpoint with alpha allocation to confirm the findings from delay in the procedure itself. As an additional consideration, definitive therapies themselves continue to improve and may have less morbidity than in the past. So in addition to the efficacy concerns for trial to support favorable benefit risk, the acute and subacute safety of the intervention has to be acceptable. The primary clinical benefit of a trial in active surveillance would be to delay or prevent morbidity. If there's significant morbidity for the local intervention itself, then any benefit in delaying progression to curative radiation or surgery would be abrogated. Acute and subacute safety and tolerability would have to be carefully measured. In addition to standard CTC-AE safety surveillance, sexual, urinary, and bowel morbidity must be carefully measured using well-defined and reliable patient-reported outcome tools. Other patient experience data, including use of a symptom library like the NCI's PRO CTC-AE, coupled with an overall side effect summary measure, could add important complementary information to the safety assessment. Demonstrating a statistically significant delay in objective progression coupled with delay or prevention of definitive radiation surgery and acceptable acute and subacute safety and tolerability using clinical and patient-reported data could be one path to traditional approval. However, important residual safety concerns would remain. The potential for reduced cure rates and synergistic post-procedural morbidity for those who do go on to definitive therapies would require further study. Post-marketing safety studies that can assess long-term safety concerns would need to include assessment of biochemical recurrence, salvage treatments, descriptive data on MFS and OS to ensure there's no large decrement, and patient-reported outcome measures of urinary, sexual, and bowel dysfunction. So to summarize, this schema demonstrates one potential trial design that could be done for a focal combination therapy with a drug or biologic primary mode of action. Patients eligible for active surveillance would be randomized to focal therapy plus active surveillance versus active surveillance alone. The primary endpoint would be objective local progression, and the key secondary endpoint would be time to local curative therapy. Acute and subacute safety would be carefully assessed, including patient-reported outcomes, to assess tolerability, urinary dysfunction, sexual dysfunction, and bowel dysfunction. To assess long-term safety, a post-marketing requirement would be long-term follow-up to assess for biochemical recurrence, salvage therapy, and continued monitoring of urinary, sexual, and bowel dysfunction, as well as serious adverse events. So there are several trial design and conduct considerations. Objective criteria for local progression would need to be defined. Assessments of biopsy, MRI, PSA monitoring, and pathology review would need to be symmetric and sufficiently frequent to be able to determine effect. Patients should be educated regarding PSA anxiety to minimize going on to curative treatment in the absence of pathologic local progression. The definition of local progression can be determined by reviewing standard practice in active surveillance programs. However, there is some heterogeneity in the different programs and newer technology that's beginning to be used, such as MRI. These criteria will need to be carefully considered. So just to conclude, there are clearly two sides of the argument for whether or not there's an unmet need for patients with low-risk localized prostate cancer undergoing active surveillance. On one hand, you could argue patients should continue to do active surveillance, and we should do a better job at preventing local treatment due to PSA anxiety, and no new therapies need to be developed. On the other hand, we know that there are a subgroup of patients who do progress and require definitive therapy. If a focal therapy could demonstrate delay in local progression, delay in morbid curative local therapy, have a favorable safety profile demonstrating lower rates of urinary, sexual, bowel dysfunction, and provide data that long-term cure rates are not adversely affected for those who do need curative therapy, then we might save even more patients from overtreatment associated with irreversible urinary and sexual morbidity. If one agrees that the space is unmet medical need, does the trial design framework adequately address the efficacy considerations and what safety and other endpoints should be monitored in the post-marketing requirement for long-term follow-up? Lastly, there are further challenges with use of focal therapies in higher-risk patients, where they will likely need to be compared to whole gland therapies. I thank you for your attention and look forward to the discussion.